Okay, part 2 of the BPH discussion, we left off with discussing finasteride and talking about adverse reactions. So because we're reducing the levels of the DHT, which is the dihydrotestosterone, the active form of testosterone in the prostate, finasteride can protect against prostate cancer, but only cancers classified as low grade. It does not protect against high-grade prostate cancer. And in fact, when given to healthy men to prevent prostate cancer, finasteride actually increased the likelihood of getting a high-grade tumor. It's generally well tolerated. Some patients report a decrease in the ejaculate volume and decrease in libido. Important to know this part here, finasteride is teratogenic to the male fetus, therefore it's contraindicated for women who are pregnant or may become pregnant. Because finasteride can be absorbed through the skin, pregnant women should not handle tablets that have been broken or crushed. And men are also advised not to donate blood if taking finasteride, or until at least 1 month after stopping the drug, to avoid the risk of having a pregnant woman as the blood recipient. Finasteride decreases the serum level of your PSA, a marker for prostate cancer. So the expected decline is 30 to 50%. So PSA levels should be determined before treatment and not 6 months later. If the PSA levels do not fall as expected, the patient should be evaluated for cancer of the prostate. Very important things to know with the dose or the use of the drug finasteride. All right, when we get into dutasteride, which is Avodart, it's very similar, but there is a difference, and I've highlighted that for you here. So the difference between dutasteride and finasteride. So first, dutasteride is the reduction in the circulating DHT is more complete. And secondly, dutasteride has an extremely long half-life, like 5 weeks. And therefore it can take months to clear the drug. So those are two properties of dutasteride that are different than finasteride. Similar to finasteride, its mechanism of action works by inhibiting 5-alpha reductase and suppressing the production of DHT. However, where finasteride inhibits only the form of 5-alpha reductase found in reproductive tissues, dutasteride also inhibits the form found in the skin and the liver. So, dutasteride produces a greater reduction in your circulating DHT, which is why they would say that the reduction in the DHT is more complete. So whether or not this translates to a greater clinical response has not been established with data yet, because we haven't gone with studies that are head-to-head. However, the examination of data from separate trials found both drugs produced a significant reduction in the size of the prostate and had good decrease of symptoms and improved long-term outcomes. The adverse effects of dutasteride, well, generally it's pretty well tolerated, and similar to finasteride, it can reduce ejaculate volume and libido. Dutasteride is teratogenic. It can be absorbed through the skin, so the same thing applies here. And it also has the same worry that it can reduce the likelihood of a low-grade prostate tumor, but it increases the likelihood of high-grade prostate tumors, so it should be not be used. It should not be used for prostate cancer prevention. With finasteride, you can open the capsules and sprinkle it on food, but you cannot do that with dutasteride. The capsule contents can be irritating to the oropharyngeal mucosa, so the capsules must be swallowed whole with a full glass of water. That's a difference between finasteride and dutasteride as well. Again, please review your summary of key prescribing information. All right, the alpha-1 adrenergic antagonists. We have 5 of those. As noted here, the most popular that I have seen would probably be tamsulosin, but lately silodosin, Rapaflo has also been things I'm coming across more often. Again, we've not compared these head-to-head, so we cannot say which one is better than the other, but the 2 newer ones, the silodosin and tamsulosin, may be better tolerated. So the blockade of the alpha-1 receptors relaxes smooth muscle in the bladder neck, the prostate capsule, and the prostatic urethra, thereby decreasing dynamic obstruction of the urethra. Symptomatic improvement and increased urinary flow develop rapidly. So that's what separates these drugs from the dutasteride and finasteride. These are the drugs that you have onset of alleviation of symptoms rapidly, And because dynamic obstruction is the major contributor to symptoms in patients with relatively small enlargement, these are much more preferred over your 5-alpha reductase inhibitors. To maintain benefits, alpha blockers must be taken lifelong. Unlike the 5A reductase inhibitors, these drugs do not reduce the prostate size. So if you had to say what are the big differences between these two classes, the alpha-1 drugs do not decrease the size of the prostate, and their effects are rapid in onset, and they're better for smaller enlargement issues, whereas the other drugs, the 5-alpha reductase inhibitors, are better for men with bigger prostates, and they do decrease the size of the prostate over time. The alpha blockers differ regarding the specificity of receptor blockade and therefore their results on blood pressure. So silodosin and tamsulosin are selective for alpha-1 receptors, which are the ones that are found in the prostate. The other ones are non-selective, so they would be blocking blood vessels, general blood vessels, as well as those of the prostate. So the selective alpha-1A receptors, the silodosin and tamsulosin, are better tolerated and more generally used. The other ones can block all alpha-1 receptors in all blood vessels, thereby it can lower the blood pressure. And actually, doxazosin and terazosin were actually developed as antihypertensive agents, and we found that there was some use in BPH later. Because of their effects on the blood pressure, the non-selective alpha-1 blockers are especially useful for patients who have hypertension, in addition to their BPH. But they can be dangerous for men with reduced blood pressure. Conversely, because silodosin and tamsulosin have little or no effect on the blood pressure, they are of no benefit to men with hypertension, but are preferred if reducing blood pressure would be a problem. We have then snuck in here is our patient-centered care across the lifespan. And again, I would say that it's important to know that these women, if women are taking these drugs, they should not use them if they're breastfeeding. And that the Beers criteria do list the peripheral alpha-1 blockers of the doxazosin and terazosin as potentially inappropriate. Of note, the reason a woman might be taking tamsulosin is that there is some indication that it can help pass a kidney stone because of its ability to relax the smooth muscle. So some women are prescribed tamsulosin, but you should not be taking it if you're breastfeeding. Adverse effects. Again, the alpha-1 blockers are pretty well tolerated. The non-selective agents can definitely cause the hypotension. And because silodosin and tamsulosin have minimal effects on vascular smooth muscle, these drugs are less likely to cause hypotension, fainting, or dizziness. However, silodosin and tamsulosin can cause the abnormal ejaculation, whereas the non-selective agents do not. And again, the alpha blockers do not reduce the levels of PSA. I would also just say as an anecdotal note, in the data, we keep saying things, and you can read this when you look these drugs up, that these silodosin and tamsulosin should be safer for blood pressure. But I will tell you that clinically, tamsulosin is a significant issue for people with orthostatic hypotension. And it's one of the first drugs in clinical practice I would get rid of if you have a patient with orthostasis. And then there is this part that if men are undergoing cataract surgery and they're on an alpha blocker, they're at risk for this floppy iris syndrome. So you should be sure to tell your ophthalmologist if you're taking these drugs prior to any surgery. And then, like I said, there's the one that's the alpha-1 blocker and 5-alpha reductase inhibitor combination. And this one here, tadalafil, is approved for men who have BPH by itself or BPH combined with ED because it can work for both of those disease states. We do have some other drugs to mention here for the BPH. Overactive bladder symptoms are often experienced by men with BPH, so sometimes we do use anticholinergics in addition for these symptoms. And those are listed there as well. There's some evidence, and people are using the Botox injections to help reduce the size of the prostate. And then I did put this here because this is something anecdotally I can tell you as well is often seen in clinical practice, is these complementary medicines for BPH. So saw palmetto is an herbal preparation used widely to treat BPH despite numerous randomized controlled trials refuting the findings to suggest that it's helpful. In 2012, a Cochrane review of 32 randomized controlled trials found no significant difference between saw palmetto and placebo. In other ones here, the American Urological Association declined to recommend anything including saw palmetto, but you will still see people using this regularly for their prostate. It's definitely in play. All right, that's short and sweet here of the men's section. As always, please reach out if any questions. Thank you.